Hi to everyone. I am Dr. MAURYA from Department of Orthodontics, School of Dental Sciences, Babu Banasidas University, Lucknow. Today I will discuss about the retention and relapse in orthodontics. So it is proved that the teeth move through bone using any orthodontic appliances. They have a tendency to return to their original position due to reorganization of periodontal ligament fibers and gingival fibers. So stabilizing the treatment results by retention procedure is an integral part of orthodontic therapy. So it should be made during the diagnosis and treatment plan. So retention protocol, it should be planned before the start of orthodontic treatment. First, we should identify the factors which may cause relapse of orthodontic treatment. So therefore, provision should be made in the treatment plan for adequate retention, keeping in the mind of destabilizing factors. There are various destabilizing factors, which I will discuss later, which causes relapse of orthodontic treatment. So retention means the maintaining newly moved teeth in position long enough to aid in stabilizing their erection. This definition was given by the MAURYA, or the holding of teeth in ideal, aesthetic, and functional position. Whereas relapse means loss of any correction which was achieved by the orthodontic treatment. So relapse is usually thought of as a rebound movement in which the teeth recoil back somewhere close to their original position by recoiling of periodontal ligament fiber and gingival fibers, and also by various factors which causes destabilizing of occlusion. So Engel summarized the orthodontic retention as follows. After malposed teeth that have been moved into the desired positions, they must be mechanically supported until all the tissues involved in their support and maintenance in their new position shall have become thoroughly modified, both in structure and in function, to meet the new requirements after orthodontic corrections. So the various schools of retentions are given over the years of various philosophies that have been put forward to explain the post-treatment stability. These are the occlusal schools, apical-based school, mandibular incisor school, and muscular school. The occlusal school, which was put forwarded by the Kingsley, he stated that the occlusion of teeth is the most potent factor in determining the stability of newly moved position of the teeth. Means if occlusion is not perfect after orthodontic treatment, then there is chances of relapse. He advocated that the use of retaining plates, which is called retainer, to maintain the position of teeth after orthodontic treatment. Next, apical-based school given by Lundstrom. He suggested that the apical base is one of the most important factors instability of achieved results, which was supported by Macaulay, who reported that the intercanine width and intermolar width, it should be maintained as originally presented to minimize retention problems. According to him, intercanine and intermolar width should not be altered permanently, especially in mandibular arch. Nance and Strong, they also substances this apical base school hypothesis. Next, the mandibular incisor school, the Grieve and Tweed suggested that the post-treatment stability was increased when the mandibular incisors were kept upright over the basal bone. According to Tweed, the mandibular incisors should be upright over the mandibular basal bone. It should be either 90-degree or it should be slightly retroclined for the stability. Next, muscular school. Rogers suggested that the proper functional muscle balance was necessary for maintenance of post-treatment stability. If there is imbalance in functional muscles, then it may lead to relapse. The important supporting factor for these schools are Morse functional matrix hypothesis, in which the soft tissue play an important role for the growth of the osseous structure. In soft tissue structures are primary factors, and bones are grown by the soft tissue. So if there is imbalance in soft tissue, then there is chances of relapse. It was also supported by the Profit's equilibrium theories. There are various causes of relapse, like unstable occlusion, periodontal ligament tractions, continued growth of maxillary and mandibular basal arch, bone adaptations, abnormal muscular forces, persistent etiology, and erupting third molars. These are the destabilizing factors. So, among this, no one single factor can be said to be the sole cause of relapse. In most of the cases, a relapse occurs due to combination of these destabilizing factors. First, the periodontal ligament traction. The teeth which have moved orthodontically, the periodontal principal fibers as well as gingival fibers that encircle the teeth, they are stretched. So these stretched fibers can contract and are thus a potent cause of relapse. So the stretched periodontal fibers as well as gingival fibers, they contract and then they cause relapse. The periodontal ligament fibers takes less time to reorganize. It takes about 4 weeks. Whereas uh, gingival fibers take more time. It takes about 40 weeks to reorganize. So there is requirement of retentions for the reorganization of these periodontal ligament fibers as well as gingival fibers to prevent the relapse. Next, due to continued growth of mammalian mandibular basal bone. So patients with skeletal problems associated with either class 2 malocclusion, class 3 malocclusion, or open bite or deep bite malocclusion. If these are treated before the completion of growth, then relapse may occur due to continued abnormal growth pattern after orthodontic therapy, which may lead to relapse of orthodontic treatment. Because due to orthodontic treatment, we cannot change our these surfaces or dominance or change the growth pattern or growth direction. And before the cessation of growth, when we complete the orthodontic treatment, then there is chances of relapse. Next, bone adaptation. So teeth moved recently, they are surrounded by lightly calcified osteoid tissue, the osteoid bone. When the tooth moves, then there is initial formation of osteoid bones, which are less calcified, and they are less able to retain or hold the tooth in the corrected position. So they are unable to adequately stabilize the tooth, and there then it may lead to relapse. Because before orthodontic treatment, yeah, normally the lamella are they are arranged perpendicular to the orthodontic force, perpendicular to the alveolar basal bone. When we apply orthodontic force, then these lamellar bones they are arranged parallel to the force. And after the cessation of orthodontic force, it takes time to rearrange the orientation of lamellar bone. So for maturation of osteoid tissue to more calcified bones, it takes time. Then muscular forces. So teeth are encapsulated in all directions by the blanket of muscles from in and around the tooth. So if there is any muscular imbalance at the end of orthodontic therapy, then there is a chances of relapse. So for this to prevent relapse at the end of orthodontic treatment, the muscular forces should be harmonized and there should be balance in the muscular force. Persistent etiology, it is also cause of relapse. If we fail to eliminate the etiology, means which are cause of malocclusion, then there is chances of relapse. So for this, during treatment planning, yeah, diagnosis and treatment planning, we should identify the etiological factor for that malocclusion. And treatment planning should be made according to the etiological factors. Erupting third molars. If third molars erupt after orthodontic treatment, they causes pressure on the teeth and it may lead to late anterior crowding and causes relapse. Generally, the third molars they erupt around the 18 to 21 years of the age. At that time, uh, most of children they take orthodontic treatment, and eruption of third molars they may cause late anterior crowding. Unstable occlusion. The various orthodontic treatment modalities may result in large centric relation and centric occlusion discrepancy. So this results in mesial or anterior lift of the dentition and causes crowding of the lower anterior teeth, and they causes relapse. So there should be no discrepancy between the centric relation or centric occlusion. Yeah, or it may be 1.5 to 2 millimeter, not more than 1.5 to 2 millimeter slide of centric occlusion to centric relation. Next, theorem of retention. Riedel has summarized the different concepts and philosophies existing into the ninth theorem, and to which Myers added another 10th theorem for this. The first theorem is teeth that have been moved tend to return to their former position. For this, various factors responsible are the musculature, apical base, transseptal fibers, and bone morphology. Because it is proven factor that the teeth that have been moved, they have tendency to return back to their original place due to recoiling of periodontal fibers or gingival fibers, and also the mineralization of or less mineralized tissues, osteoid tissues. So whatever the reason, it is general agreement that the teeth should be held in their knee position for some time to reorganize the periodontal fibers and gingival fibers, and for the complete ossification of the osteoid tissue. Second theorem is elimination of the cause of malocclusion will prevent reoccurrence. So for this, to prevent the malocclusion, to prevent the relapse, the cause of malocclusion should be identified at the time of diagnosis. Until more is known about the causative factors, little can be done about their elimination. When obvious habits such as thumb sucking, finger sucking, lip biting, they are cause of malocclusion. So these should be eliminated before or during the treatment to prevent relapse. Next theorem. The malocclusion should be overcorrected as a safety factor. So it is true for every orthodontic corrections, both intra-arch as well as in inter-arch. The rotations, corrections, or treatment of class 2 and class 3 malocclusion, they should be overcorrected. Like in class 2 corrections, the overbite and overjet should be edge to edge. Molar should be corrected in super class 1 cases. And in correction of class 3 malocclusion, there should be positive overjet after the orthodontic treatment. And for rotation, it should be also overcorrected as a safety measure. Theorem 4. Proper occlusion is a potent factor in holding teeth in their corrected position. So the orthodontist should not restrict treatment to achieving a good intercuspation when the jaw are fluid, but should aim further at an excellent functional occlusion. That means the harmonious occlusal contact during functional movement of the jaw to prevent relapse. Next theorem. Bone and adjacent tissues must be allowed to reorganize around newly positioned teeth. Histological studies have shown that the bone and tissues around the teeth that have been moved require considerable amount of time before complete mineralization occurs. Because after tooth movements, the tooth there is formation of osteoid tissue, which are less calcified, and it takes time to for the complete mineralization. If a complete mineralization does not occur, then there is chances of relapse. So for this, some type of fixed or removable appliances that is passive in nature and have no positive fixation force on the teeth. It should be used allowing natural functioning of the tooth. Theorem 6. If the lower incisors are placed upright over the basal bone, they are more likely to remain in good alignment. So attention should be directed to the proper angulation and placement of the mandibular incisors. It should be placed upright over the basal bone. If any errors in positioning of the mandibular incisor is present, then it is better to place the lower incisors in lingual direction rather than labial inclination. Theorem 7. Correction carried out during period of growth are less likely to relapse. Hence, treatment should begin at the earliest possible age. The advantages of treating during the growth period are it prevents progressive, irreversible tissue and bony changes. And we can utilize the maximum growth potential during growth periods. And also allow interception of malocclusion before excess dental and morphological compensations to occur. And also it allows correction of skeletal malrelationship while sutures are immature and more amenable to alteration. Theorem 8. The further teeth have been moved, the less likelihood of relapse. It may be possible that positioning far from the original environment will produce equilibrium states permitting more satisfactory. But does not it mean that when the teeth have moved a great distance, the patient will need less attention. They need retention by proper time. Theorem 9. Arch form, particularly the mandibular arch, it cannot be permanently altered by appliance. Macaulay have suggested that intercanine and intermolar width, they are uncompromising nature, that they should be considered as a fixed quantity and build the arch around them. So we should not alter the intercanine and intermolar width. So it should be placed as a reference measurements, a reference for the arch over arch buildup. So hence the alteration of existing arch form results in increased risk of relapse. Theorem 10. Many treated malocclusion, it requires permanent retaining devices. This theorem was aided by the MAURYA. So certain malocclusion might require the patient to be fitted with permanent retaining devices. This is true in cases that have not been treated to achieve occlusal goals that stand for the stability. Now, why retention is necessary? Retention is necessary for gingival and periodontal fibers which require time for reorganization when an active appliance is removed. It takes time for the reorganization. And also the soft tissue pressures are likely cause relapse if the teeth are placed in unstable position. Or if muscles are imbalanced, then they cause relapse. And growth changes can alter the orthodontic rhythm. If treatments are completed before the completion of growth, then there is chances of relapse. The principles of retention. First, the relapse potential may be predicted by evaluation of initial occlusion. And teeth usually want to return their original position. This is due to gingival fibers and unbalanced lip-tongue force. So for full-time retention is required for 3 to 4 months initially to allow for the reorganization of periodontal ligaments. And retention should be continued for at least 12 months in non-growing patients or until growth has ceased in growing patients. So in adult patients, the permanent retention be required because of lip, cheeks, and tongue pressure that are too large to balance out. So type of retention. Retention planning is divided into 3 categories depending on the type of original malacry and treatment instituted. So there are 3 types of retention protocols. One is for limited or no retention, moderate retention, permanent or semi-permanent retention. So limited retention or no retention, it occurs in cases of corrected interior crossbite with adequate overbite. If we correct the anterior crossbite with positive overbite, then there is a less chances of relapse. So it requires limited or no retention. Also corrected posterior crossbite with good axial inclination and steep cusp of posterior teeth. It requires limited or no retention. In serial extraction cases, also block out teeth that are treated by opening up the space and allowing their eruption. It also requires limited or no retention. Next, moderate retention. Most of the cases treated orthodontically fall in this group. Like class 1 non-extraction case characterized by protrusion and spacing of maxillary incisors. Class 1 or class 2 extraction cases, particularly in maxillary arch until lip and tongue pressure becomes normal. Corrected deep overbite, early correction of rotated teeth before their root formation is complete. Cases involving ectopic eruption of teeth or presence of supernumerary teeth. Corrected class 2 division 2 cases requires extended retention for muscular adaptation. Next is permanent or semi-permanent retention. In cases where mandibular arch expansion, especially when we change the intercanine width, which has been a part of space provision without ensuring good occlusion, it requires permanent retention. Cases of generalized spacing, severe rotation or labiolingual displacement, particularly in adults. Midline diastema, patient exhibiting abnormal muscular or tongue habits, expanded arch in cleft palate patient, or certain class 2 division 2 deep bite cases. It requires permanent or semi-permanent retention. Thank you.